Welcome to our annual CDC Public Health Grand Rounds Year in Review for 2018. Every Grand Round session is an opportunity for our viewers to learn what CDC and others are doing in the world of public health. And this year, as always, we address some very challenging topics. Let's hear from Dr. John Iskander, Scientific Director for Grand Rounds.
Thank you for joining us today. The goal of CDC Public Health Grand Rounds is to share some of the important work that CDC is doing around the world to save lives and protect people. Each Grand Round session is the result of a rigorous process which takes up to 120 days to prepare. This attention to detail ensures that our audiences received up-to-date, scientifically accurate, and usable information, whether they are clinicians, researchers, students of public health medicine and nursing, or the public that we serve. In addition to the session, we also offer Beyond the Data interviews, providing an opportunity to expand on some of the key points made during the session. We've selected a few moments from each of our 2018 Grand Rounds and Beyond the Data interviews to share with you here. After you view this retrospective, you may want to visit our Grand Rounds on-demand website, where you'll find complete recordings of all of our sessions. Remember that continuing education units are available for sessions up to 2 years after they originally air. We launched our new website in 2018. This site will make it easier for you to find everything you need about the topics we feature in Grand Rounds. Take a moment to subscribe to our site and receive notices of updates as they occur. Also remember that all Grand Round sessions have continuing education credits available for doctors, nurses, pharmacists, veterinarians, and other health professionals. We hope you enjoy this Grand Rounds Year in Review. Join us for our new offerings starting in January 2019. We will kick off the 2019 season with an excellent session on HPV.
January 2018. Severe influenza. This season of Grand Rounds kicked off with a harsh flu season caused by Influenza A H3N2. Dr. Ann Schuckett, Principal Deputy Director at CDC, talks about one of the most difficult flu seasons in years.
Today, we have an opportunity to hear from experts from CDC's Influenza Division about the science, the surveillance, and the service. You'll hear about what we know and what we wish we knew. You'll hear about what we're doing, and you'll get a glimpse into the future of what we hope we'll be able to do to better control this very, very difficult virus. You're going to hear about why the H3N2 virus is so incredibly difficult to work with, to predict, and to prevent, and what we're doing about that. And you'll also hear about today's tools, antivirals, and the many different types of influenza vaccines that we have right now.
So there are influenza epidemics each season. I think a lot of people are asking, is this year an epidemic? And the answer is always yes. Every year it is an epidemic. But there are periodically pandemics, and that is where the entire globe has the emergence of a novel and a highly transmissible and sustained movement of a new flu through the population. So influenza has a significant annual burden each year. If you look at the United States and look at the high end of the numbers, there are upwards of 56,000 deaths per year, 710,000 hospitalizations, and 35.6 million symptomatic cases that are estimated each year.
Dr. Phoebe Thorpe and Dr. Alicia Fry discussed action steps for people who think they may have the flu.
Today's session was about severe seasonal influenza. What should you do if you suspect you have the flu?
Well, that's a great question. Now, if it's very early and you're just starting to have symptoms, it's probably worth calling your doctor. This is especially important if you're an older adult, 65 or older, or if you're a parent with a very young child, or if you have any underlying medical conditions such as diabetes or heart problems or lung problems. If you get to your doctor early and get antivirals early, these drugs can help you. They can reduce the severity of your illness and they can make you feel better quicker.
Tell me, what can you do to prevent yourself from getting the flu?
Well, the best way to prevent yourself from getting the flu is to get the flu vaccine. Now, right now, we recommend that the flu vaccine is given to everybody 6 months and older every year. And even we like people to get vaccinated before the flu season, but even if the flu season is already ongoing, it's not too late to get vaccinated. So if you haven't been vaccinated, go ahead and get vaccinated.
And you had mentioned there are some really important individuals that should be vaccinated because if they get flu, they have a chance of getting even more sick than people who are relatively healthy. Can you remind me which groups those are?
That's right. There are some people who are at higher risk of having severe complications from flu. Those are the very young, so children under the 2 and under, the very old, so adults 65 and older, pregnant women, people who have immunosuppression, and people who have certain underlying medical conditions like heart disease or lung disease or diabetes.
February 2018. Million Hearts 2022, a compelling call to action. Dr. Ann Shuckett opened the session with a personal story, and Dr. Janet Wright shares the facts about cardiovascular disease.
Like many of our grand rounds, today's topic is personal. My mother's father, uncle, and brother all died from heart attacks in their 50s. But thanks to stopping smoking, high blood pressure control, and cholesterol maintenance, my mom is still complaining about my hairstyle at age 89. I visited the cardiologist with her last week, and he says she's going to be doing it for a while. Cardiovascular disease, heart disease, and stroke is still the leading cause of death in the United States. It kills more than 800,000 Americans each year. It's too common, it's too costly, and too few people do the simple things they can do to prevent it.
Our partners, though, taught, they learned, and they shared very valuable lessons in this first phase of work. First of all, a catchy aim intrigues and inspires, and it happens quickly, so you better be ready to tell people what to do. Public health and healthcare rowing their very unique boats toward the same destination just makes sense. We learned that less is more, choosing a few high-impact strategies and measures and offering flexibility in implementation is one secret to progress, if not immediate success. We know that those who are deeply invested energize everyone and they make progress possible. We learned early on to connect and convene through websites, listening sessions, webinars, and particularly social media. We learned to keep the signal strong by anticipating the inevitable changes in the world of science. And then finally, we learned to seek and celebrate those positive deviants, those who are doing extraordinary work, and try to lift them up.
For our Beyond the Data segment, Dr. Iskander spoke in depth with Janet Wright.
For our audience, can you please remind us what the Million Hearts program is?
Happy to, John. It's a national initiative co-led by CDC and CMS that's founded on the idea, really the groundbreaking idea, that if you took the assets and expertise of public health and combined it with the payment and policy that exist in healthcare and focused partners on a common goal, and you lit a timeline underneath it, that you could get a big goal done. And so the original Million Hearts launched in 2012 and was a 5-year initiative to prevent 1 million cardiovascular events, primarily heart attacks and strokes, over that 5-year period.
So we have some information now about what's been achieved in that first phase of Million Hearts. What have we learned from some of the studies that have been published?
Yeah, what we know is that progress was made. We also know that progress happens slowly. We will still be getting data on that 5-year period for about another year and a half. So final report on the number of events prevented will be available in 2019. But as all things true in science, we can make some predictions based on what's happened to date. We think that by the time 2019 rolls around, somewhere close to 500,000 events will have been prevented. The events are prevented when the risk factors are controlled. And what we know is that progress was made in blood pressure control, about 1% improvement per year. In cholesterol management, about 2% per year improvement was seen. Smoking prevalence did drop through all the work that's done by CDC, its partners, and really many organizations and entities around the country. But we didn't make any headway at all in sodium reduction, which has a huge impact on the numbers we're trying to control. So what I'd say in summary is not all the targets were met, so we predict we're going to fall short of the 1 million prevented.
March 2018, the global introduction of new vaccines, delivering more to more. This session discussed the importance of vaccines. Did you know that vaccines prevented over 23 million deaths that would have taken place from 2011 to 2020?
The first 6 vaccine-preventable diseases targeted with vaccination were diphtheria, pertussis, tetanus, measles, poliomyelitis, and tuberculosis. Following the initiation of the WHO EPI program, we saw a substantial reduction in the burden of preventable childhood illnesses and deaths. It is estimated that over 23 million deaths will be averted from vaccines during 2011 to 2020 in 73 Gavi-eligible countries.
As you can see here, with a child from a rich family, up to 9 times more likely to be vaccinated than a child from a poor family. And finally, missed opportunities for vaccination will have to be reduced. This could quite easily be done by just checking the immunization status of all children and of patients of other age groups whenever they access the health services.
When it comes to making investment decisions in health, vaccines are a very attractive option. They not only provide return on investment in terms of decreased mortality and morbidity, they also make sound economic sense. We can all encourage the introduction of new vaccines by reinforcing how vaccines play a role in the broader economy and that they have a very positive return on investment.
In our Beyond the Data segment, Dr. Phoebe Thorpe asked panelist Dr. Mantell about the new vaccines discussed during the session.
Today's session was about global immunizations. Some vaccines have been around for a while, but today's session really focused on new vaccines. What are new vaccines and why are they good?
We've been using vaccines in the expanded program of immunization for decades, but they were limited to about 6 antigens. Now, in the last decade, we've actually been able to come up with vaccines against really severe childhood diseases, such as meningitis, such as pneumonia. There is now also a vaccine against, the second vaccine that we actually have against cancer, human papillomavirus vaccine. There is a vaccine now against typhoid, which is a typhoid conjugate vaccine. So really what we're seeing is that we're having vaccines now against major diseases that affect children and will enable us, and enable us already, to reduce childhood mortality significantly. So all of this is new, and what we've been doing in the last decade is to actually ensure that these new vaccines are also implemented in those countries which usually wouldn't have had access to the vaccines.
April 2018, working together to eliminate the threat of hepatitis B and C. CDC Director Dr. Robert Redfield introduced this session with a strong statement.
We must never underestimate, I've said this before, we must never underestimate the possible. Hepatitis B and C will be eliminated and relinquished into the history books of medicine, and I would state that now is the time to begin that task.
A large proportion of people are unaware of their status and not receiving those treatments that can be helpful for them. What we have found in our demonstration projects in collaboration with our local partners is that if you develop culturally appropriate, linguistically appropriate programs, you can do a very good job of engaging people into the testing process and getting them reliably linked to care and beginning to receive the treatments that they need. Now, the good news, as Bob just mentioned, is that HCV can now be cured. But we also have a problem with a large proportion of people still unaware of their infection, because this is a very silent infection until very late stages, with only about 1 in 5 having received treatment. One shining example of what can be done is the Cherokee Nation of eastern Oklahoma, where the leadership set an elimination goal for the population, recognizing the health disparity that is hepatitis C for American Indians. They adopted a universal testing policy. They put in provider education and other interventions to prompt testing and linkage to care. They got mid-level providers, such as pharmacists, involved in providing care, and they found out ways to finance all of this within their health system, testing and treatment. And as a result, they have tested over the 50% of the adult population in about 3 years. And they are doing an excellent job of referring them to care, and they're getting very successful outcomes of those people who are getting treated. So they are making excellent progress to the goal that they have set for themselves.
San Francisco is heavily burdened by hepatitis C. We had about 1,000 new case reports in 2016, and among those case reports, 30% of them were African American, which points to a significant racial disparity in our hepatitis C burden among that group. Based on our best information, it's estimated that 22,000 San Franciscans are antibody positive for hepatitis C, and about 12,000 people are currently infected with hepatitis C. People who inject drugs make up 68% of our active hepatitis C infections, with men who have sex with men, baby boomers, and trans women also experiencing disproportionate burden of hepatitis C. We also believe that culture change is necessary in the way that we address hepatitis C in the community. We have to really shift away from a lot of antiquated ideas about hepatitis C, such that hepatitis C is unavoidable for people who inject drugs, that cures are unattainable, that anyone is in any way undeserving of hepatitis C treatment. And to shift these narratives, we really believe it's essential to involve peers to lead our community engagement efforts.
Dr. Phoebe Thorpe discussed the impact of global hepatitis with Dr. Cowie from the WHO Collaborating Center on Viral Hepatitis.
There's been some amazing work going on in a number of countries around that. Mongolia, for instance, who's got a high prevalence of both hepatitis B and hepatitis C, have set the objective to screen the entire adult population for both of those conditions, and are making huge strides in actually diagnosing every adult in the country with Hep B or Hep C to enable those treatment mechanisms to follow. So for a low or middle income country, it's an amazing commitment. And there are other sort of champions of this as well.
May 2018. Be antibiotics aware. Smart use, best care. Did you know we have a serious problem with resistance to antibiotics? This Grand Round session highlights the problems that arise when we take antibiotics when they're not appropriate.
Clostridium difficile infection is a serious consequence of antibiotic use that disrupts the normal microbiome that protects us. CDC estimates that C. difficile causes 453,000 infections and 15,000 deaths in the United States annually. C. difficile infections occur both in hospitalized patients and outpatients after antibiotic use. These infections can become recurrent and are costly and potentially fatal consequences of antibiotic use. And thus, prevention of C. difficile infection is key.
Most prescribers already know you're not supposed to prescribe antibiotics for viral illnesses. So what's the problem? And colleagues of mine and I think we've been using an implicit model of physician behavior that's flawed. We've presumed that clinicians are reflective, rational, and deliberate about what they're doing. And if we just provide the right information at the right time, they will do the right thing. And so we've tried any number of interventions to educate prescribers and remind them about appropriate antibiotic prescribing, but that really has not worked. And finally, clinicians might want to follow guidelines, but feel the guidelines don't really apply to the patient that's right there in the room with them.
In our Beyond the Data interview, Dr. Iskander spoke with Dr. Fleming Dutra about the need for antibiotic stewardship.
Hello, I'm Dr. John Iskander. Welcome to CDC Beyond the Data. I'm here today with Dr. Catherine Fleming Dutra. Deputy Director of CDC's Office of Antibiotic Stewardship. So, Catherine, we heard at today's Public Health Grand Rounds about some of the issues around antibiotic use and antibiotic resistance. Let's start with a working definition of what antibiotic stewardship is.
So antibiotic stewardship is the effort to measure and then improve antibiotic use so that antibiotics are only used when needed, and when needed they're used correctly, meaning the right drug at the right dose for the right duration.
I think a lot of our audience probably this is not news to them that antibiotics are not indicated for uncomplicated colds. But there are a number of other diagnoses, common diagnoses, for which antibiotics may either almost never be indicated or that there may be alternatives to antibiotics. What are some of those other common conditions?
It's a great question. So, for example, I'm a pediatrician, and so one of the common infections that pediatricians see is acute otitis media, or middle ear infections. Antibiotics are sometimes needed to treat middle ear infections, but they're also the clinical practice guidelines also recommend a strategy called watchful waiting, in which you wait a few days for mild ear infections to see if the child gets better before deciding whether or not they need antibiotics. Additionally, in adults, sinusitis is a very common infection, or sinus infections, but that's another infection in which professional guide or national clinical practice guidelines from professional societies, some of them recommend watchful waiting before deciding whether antibiotics are needed, because many patients will get better without antibiotics.
June 2018, encore presentation of Prevention and Control of Skin Cancer. Dr. Iskander checked in with Dr. Lisa Richardson, Director of CDC's Division of Cancer Prevention and Control, to see what was new.
I think there may be also misperceptions about, do these apply to people of all skin types? Specifically, do these recommendations apply to people of color?
So it's really hard. So we think, if you're African American with darker skin, that you're not at risk, but that's not true, because the main reason people are at risk are sunburns. And if you stay outside long enough, almost anyone can sunburn. So if we should be aware that the risk may be lower, but you still need to protect yourself: hat, glasses, sunscreen, cover yourself up.
And there is evidence, I think, of some health disparities in the stage at which skin cancers are diagnosed in African Americans. Is that correct?
Yeah, so African Americans tend to be diagnosed with higher stage of skin cancer at diagnosis. But one of the problems with that, or what we just talked about, is I think a lot of people are not aware that they're at risk for skin cancer and may see things or feel things that they don't follow up on. And providers as well. We think sometimes that people of darker skin aren't at risk either, and we don't take it quite as seriously as we should.
July 2018, encore presentation, Primary Prevention and Public Health Strategies to Prevent Neonatal Abstinence Syndrome. Dr. Thorpe spoke with Rear Admiral Wanda Barfield, the Director of the Division of Reproductive Health at CDC.
Your session from 2 years ago about neonatal abstinence, we're rerunning. Part of the reason we're rerunning it is because the opioid epidemic continues to worsen in the United States. What is neonatal abstinence?
Neonatal abstinence syndrome is something that I know very personally. In addition to directing the Division of Reproductive Health, I'm also a neonatologist, which is a specialist in pediatrics that focuses on the care of critically ill newborns. Neonatal abstinence syndrome is a withdrawal syndrome that occurs for babies who've been exposed to opioids during pregnancy. Now, this may occur under a variety of circumstances, but the challenge here has been more recently we've seen it as a result of the opioid crisis. So neonatal abstinence syndrome can occur when there's withdrawal that a pregnant woman has after her baby is born, and that baby has been exposed to either prescription substances that include substances like Vicodin, OxyContin, or it can be illicit substances that can also include heroin, or it can be exposure to medication-assisted treatment, such as buprenorphine or methadone. And these infants have symptoms that occur about 48 to 72 hours after birth. And these symptoms are fairly distressing. They include things like excessive crying, inconsolability, they may have difficulty feeding, they may have watery stools or diarrhea, they may also have seizures. And so these particular symptoms and signs need to be treated, and they need to be treated in a gradual method.
August 2018. Preventing childhood obesity, eating better, moving more. Did you know that 1 in 5 children in America have obesity? There are actions that we can take.
Today, 1 in 5 children in America have obesity. Even more people are on the road to poor health, with 1 in 4 young adults too heavy to be eligible for the military, and 2 in 5 adults with obesity. Obesity increases a child's risk for acute physical and psychological health concerns, including early signs of type 2 diabetes, asthma, sleep apnea, fatty liver, as well as having lower self-esteem and being at greater risk for bullying. The percentage of children and teens affected by obesity has more than tripled since the 1970s.
As I travel across the U.S. and talk to parents, I've realized that many think that their children are going to grow out of it, that this is just a phase. But our data shows that obesity is not a phase. Compared to children with healthy weight, kids who are overweight in kindergarten are 4 times more likely to have obesity by 8th grade, with risk continuing into adulthood.
Family child care providers are small business owners. They're small operations with one person doing the work of many. So it's really critical that we tailor supports and services accordingly when we're trying to work with that population. It's also important to remember that these centers and family child care homes where children are learning and playing and growing are not labs. They reflect the communities around them, the people who work in them, and the families that attend them. In summary, early childhood is a highly influential setting in which healthy habits can be shaped for millions of children.
We know that about 95% of all school-aged children are enrolled in schools and spend, on average, almost 7 hours a day there, 5 days a week. And many stay on school grounds afterwards for after-school programs and enrichment activities. And this broad reach is critical, given the high prevalence of childhood obesity and existing disparities. And schools are a natural setting to both learn about and practice health behaviors. So our CDC school health guidelines, they present an evidence-based approach to promoting physical activity and healthy eating in schools with a focus on changes to the school environment and policy. And through the translation materials we develop and the funding we disperse to states and to partner organizations, we work to support schools and groups that work with schools in adopting strategies to increase children's opportunities to move more and eat well while they're on school grounds. And that's before, during, and after school.
Students who are overweight or obese often do not feel good, including experiencing higher rates of depression. I then ask what it was like for adults to go to work and not feel their very best physically or mentally. The universal answer is that they're not very productive and do not want to be at work. When teachers and administrators realize that they have students in their district or in their classrooms who regularly do not feel well, it resonates with them.
Dr. Iskander spoke with 2 of our panelists. Dr. Heidi Blank is CDC's Chief for Obesity Prevention and Control. Dr. Iskander wanted to know more about the problem and the important solutions.
So that's obviously clearly a population health issue. I think some of our audience may be familiar with some of the eventual complications such as type 2 diabetes, but there's really a much longer list of risks of obesity. Could you just kind of take us quickly sort of head to toe on that?
So in childhood, when children have obesity, they already are at risk for a number of acute conditions. Some of these are structural, like bone problems or sleep apnea. There's also mental health issues with children, including bullying and stigmatization. We see increased absenteeism from school. If obesity continues and is persistent and it goes into adulthood, as you mentioned, type 2 diabetes is a large concern of obesity, but also cardiovascular disease. And we now have 13 cancers that are causally linked to obesity.
So why is that setting important for obesity prevention, and what can parents and child care providers do to have an impact in that setting?
So we know that a large number of our children spend their days outside the home. So over 60% of our toddlers are in childcare for over 30 hours a week. So although parents and aunts and uncles and grandparents are very important in the household setting, our childcare providers really are that first line of defense and first line of healthy habits during that school week. We have a lot of children who are benefiting from high-quality childcare for school readiness and early literacy, but we really need to make sure, too, that those healthy habits are established during that childcare day. We know that obesity is not a simple disease. There are many factors that cause obesity. So the science is evolving, but we know that better foods, so those that are lower in calorie and high in nutrients, so things like fruits and vegetables, getting adequate physical activity, reducing screen time or sedentary time, but also stress management and sleep are really important in children. A lot of initiatives these days use something like a 10-5-2-1-0 approach. So 10 hours of sleep, 5 fruits and vegetables, less than 2 hours of screen time, 1 hour of physical activity, and 0 sugary drinks.
Next, Dr. Skander interviewed Mickey Duran from the Appleton School District in Wisconsin. She shared some of the successes they have had with new programs.
It's very important, the physical activity that they have, how it gets their brains ready to move, how it helps them emotionally to be more stable, to be more present in classrooms. It reduces behavior. I think if you talk about anybody in schools right now, they'll talk about behavior issues that they have with their students. But it's really because it goes back to their physiological way that they're just not prepared to be at school or to listen. And I think that when schools understand that there is that connection and that we do need to make sure that we're providing a healthy environment for them, that it helps them and the students to be better. So they do work together.
September 2018, Surveillance for Emerging Health Threats for Pregnant Women and Infants. CDC Director Dr. Robert Redfield introduced the session with a reminder that surveillance systems are the backbone of helping us put science into action. He talks further about threats to pregnant women.
As a science-based, data-driven service organization, CDC uses data in every aspect of our work, and surveillance systems are the backbone of helping us put science into action. The health risk of pregnant women, for them, Zika serves as a stark reminder about the importance of surveillance, the vulnerability of pregnant women and infants to infectious diseases. Pregnant women face some special challenges, unique physiology, changes in the immune system, various pregnancy complications. But as we all know too well these days, it's not just infectious diseases, but pregnant women are challenged by the opioid crisis. Today, about 100 babies are born a day in the United States with neonatal abstinence syndrome. One baby is born every 15 minutes. I recently just got back from West Virginia, where I went to some of the neonatal centers that take care of neonatal abstinence syndrome, and I was sort of shocked to find out that 5% of all the pregnancies now in West Virginia give birth to a baby with neonatal abstinence syndrome. Babies are born preterm, low birth weight, and they have significant risk for poor health outcomes. Longitudinal surveillance data in their systems can help us better understand the possible outcomes for these children and begin to recognize the importance of various social determinants of health.
The timely detection and treatment of syphilis in a pregnant woman is essential for preventing congenital syphilis and its complications. Because of this, CDC recommends screening all pregnant women for syphilis at the first prenatal visit, regardless of their perceived risk.
As you heard today, there are multiple threats that impact mothers and infants. And today, I will discuss how surveillance data can inform our response to emerging threats and ultimately clinical practice. As a practicing obstetrician and gynecologist, my everyday clinical decision-making relies heavily on evidence-based clinical recommendations and guidelines. Guidelines published by the CDC and the American College of Obstetricians and Gynecologists are based on different types of data. Caring for pregnant women and infants still relies very heavily on the interpretation of observational data. While randomized controlled trials are the gold standard, Pregnant women are often excluded from these trials due to concerns about unknown risks to the fetus. Observational data from surveillance systems provides another source of evidence to inform clinical recommendations.
In Beyond the Data, Dr. Thorpe zeroed in on the challenges with Zika virus. She spoke with Dr. Mike Fraser from ASTO.
We didn't know a lot about it. And over time, we learned about its transmission and who was more at risk and things like that using data. But we also, in addition to clinical data, learned a lot about communities and what the burden of Zika was in a place. And we also used data on the environment. So a lot of things people forget, as the mosquitoes live somewhere, we had to monitor them, look at some of the risk factors in communities, and use those data to address the health challenges of Zika.
If somebody was interested in learning more, where would they go? Where could they find out more?
Sure. Well, I think specifically if they're interested in Zika and some of the birth defect surveillance work that's going on, cdc.gov/birth defects would be a great place to go. If they're interested in what states are doing, feel free to Google your state health department and/or ASTHO, ASTHO.org.
October 2018. Safe Sleep for Infants. In October, we learned about progress made in preventing sleep-related deaths in infants. This is an important session for both healthcare providers and families.
There are approximately 3,500 sleep-related infant deaths in the United States each year. These deaths, also known as sudden unexpected infant deaths, or SUID, are deaths of babies less than 1 year old, which happen during sleep or in the baby's sleep area. This includes infant deaths from sudden infant death syndrome, or SIDS, and other undetermined causes, and accidental suffocation and strangulation in bed. Recent U.S. data has shown that the peak age of these tragedies is between 1 and 2 months. Things we know increase the risk for sleep-related infant deaths are non-supine, so stomach or side sleep position, sharing a sleep surface with another person, use of a non-firm sleep surface, such as an adult bed, use of soft bedding in the infant's sleep area, so that's things like bumpers, comforters, pillows, blankets, or even stuffed animals, as well as letting an infant get too hot while sleeping due to either high room temperature or excessive clothing. Prenatal use of alcohol or tobacco, and exposure to environmental tobacco, or being in the care of an adult under the influence of alcohol are also known to increase the risk. This means, to reduce the risk for every sleep at night and at nap time, infants should be placed on their backs, on a separate sleep surface, preferably in the same room as their caregiver. The infant's sleep surface should be firm, flat, and level, so a surface like a crib, portable crib, or bassinet with a tight-fitted sheet. It should be free of thick blankets or pillows, bumper pads, or other soft objects. And the baby should be kept cool while sleeping, dressed in no more than one layer more than an adult would comfortably wear in that environment. It's also recommended that women stop smoking during and after pregnancy, and that parents not allow anyone to smoke around their infants. Women should also avoid alcohol use during pregnancy, and anyone responsible for infant care should not be under the influence of alcohol.
Dr. Thorpe interviewed 2 experts for our Beyond the Data segments. First, we will hear from Dr. Samuel Hankey from Cincinnati Children's Hospital and Charlie's Kids Foundation. He shares his very personal story.
Your story today about your son Charlie is very powerful. You told us about his death and how you have turned that tragedy into an amazing way to prevent future deaths. Can you tell me a little bit about that and your journey?
My wife Maura and I lost Charlie back in 2010. He would have been 8.5 years old now. He was born a beautiful, healthy baby boy. He was actually the same weight and length as me, 7 pounds and 11 ounces and 21 inches. He was really perfect in every way, and we were amazed at the first sight of him and celebrated life with him, and really started to settle in a routine as new parents. He was our firstborn son. Like all babies, Charlie was fussy, and one night I offered to give my wife a break. She was breastfeeding and needed some much needed rest, and I told her I would hold him while she got some sleep, and I finally got Charlie to settle, and I sat down on the couch to watch some TV while holding him, and I nodded off to sleep. I wasn't trying to nod off to sleep, but I nodded off to sleep, and when I woke up, Charlie was gone. He was asleep on my chest, and life has never been the same since that.
Dr. Goodstein, a neonatologist from Wellspan York Hospital and member of the American Academy of Pediatrics Task Force on SIDS, spoke with Dr. Thorpe about the impact of this important public health story.
So interestingly, we had some success in the 90s with reducing the SUID and SID deaths. Can you tell me a little bit about that?
Sure. I think this is one of the greatest public health success stories of the late 20th century. And the American Academy of Pediatrics lists it as one of the 7 top success stories in terms of pediatric care. So this is really a wonderful story. So back before the early 90s, we were having about 8,000 babies die of these kind of sleep-related deaths. And it was fairly consistent despite such things as using home monitors and other interventions. But what we started seeing as people reviewing data is that they were finding that babies were frequently found face down. There was often soft bedding around them. And one of the key research articles that came out was actually from New Zealand and Dr. Ed Mitchell, and they did the benefits of good death scene investigation. They were finding these lambskins and babies being face down almost always when they were dying of these unexpected deaths. And so when enough data came out in 1992, the American Academy of Pediatrics made a recommendation that babies should sleep on their backs, not their tummies. And then in 1994, with other partners joining in, including the CDC, we started the Back to Sleep campaign. And with that push to get people to keep babies on their back to sleep, we saw the rate of SIDS cut in half.
November 2018. The National Diabetes Prevention Program, Changing Lifestyles to Prevent Type 2 Diabetes. Did you know that 30 million Americans have diabetes, and another 84 million Americans, or 1 in 3 adults, have prediabetes? Did you also know that making basic lifestyle changes may be able to prevent those with prediabetes from progressing?
People with prediabetes have an increased risk of developing type 2 diabetes, heart disease, and stroke. Prediabetes does not mean an inevitable progression to diabetes. Research shows that people with prediabetes who take part in a structured lifestyle change program can cut their risk of developing type 2 diabetes by more than half. People over 60 can cut their risk by nearly 3/4. The National Diabetes Prevention Program, or DPP, is designed to help people make changes in diet, exercise, and behavior.
There are over 30 million people who have diabetes. That's about 9.4% of the US population. It's expensive, $237 billion in direct costs and $90 billion in reduced productivity and disability. Prediabetes is a condition where blood sugar is higher than normal, but not high enough yet to constitute type 2 diabetes. But as was noted, it does put you at increased risk for other serious health problems, including heart attack and stroke. Prediabetes really is a significant health issue in our nation. So as we work to improve the outcomes for those who already have diabetes, it is imperative that we really do focus and invest in preventing new cases of type 2 diabetes. Fortunately, we have strong evidence that for the prevention or delay of type 2 diabetes in those at high risk.
I know by the session number, it's like jumpstart your physical activity. We hold it there at the Wellness Center. And first I thought, it's more than a gimmick. It's really, a lot of people are intimidated by going into a wellness center or gym on their own. We heard that when we held the first session there. I wouldn't have come unless I was with the group and group support. Now I see it's approachable and I'll continue to attend. And that was great. And that relationship is fantastic. And even when we leave and that program ends, those two organizations are still there. So that's our ultimate goal, is to really show individuals who might not be familiar with those resources that they're truly available for them to use throughout their lifetime.
In our Beyond the Data segment, Dr. Thorpe interviewed Dr. Ann Albright, Director of the Division of Diabetes Translation here at CDC. We learned more about action steps people with prediabetes can take.
We have been hearing about a lifestyle change program that can cut your risk of developing type 2 diabetes in half.
The lifestyle program is one in which you are getting information on nutrition, diet, which one would likely assume you would, also get information on physical activity, and importantly on stress reduction, learning coping skills. But the beauty of this program is that you are discovering and learning what works for you. It allows you to really think about things going on in your life, what your barriers are, what your challenges are.
If somebody wanted to know more about where to join a lifestyle change program or one near them, where would they go? What can they do to join one?
I would suggest first, as we've been saying, to talk to your healthcare provider. Be sure that you've taken that easy risk test, which you can take online at doihaveprediabetes.org. And then again, based on your risk test, speak to your clinician. Your clinician may certainly be aware, and we are working with many partners to help clinicians around the country know where those programs are. Find out from them. You can also go to our website at CDC, which is www.cdc.gov/diabetes/prevention.
We hope you've enjoyed this year in review, and we hope you'll take a moment to go to our Grand Rounds website and watch those sessions that piqued your interest. And if you're not already a subscriber, take a moment to sign up so you receive notices of future topics. Thanks again for your time.